Hi, my name is Claudine Lewis. I'm a respiratory therapy student, and I'm going to go over some mechanical ventilation with y'all. Here we use the Draeger Evita XL, and right now I've got it in standby mode because the beeping is making me crazy. So, I'm going to hit start. I've got it in SIMV. I've got my test line hooked up. So, this would be in the ET tube with the suction. Actually, that's not right. This would be the patient's lung, and this would be the suction, which will be hooked to the suction in the wall. So I'm in SIMV mode with autoflow. I have an I to E of 1 to 3.3. O2 is 50%. Tidal volume is around 400. That is not bad for me. Tidal volume, inspiratory time is 1 second. Frequency is 14. PEEP is 5. Pressure support of 5. So the dark ones are the machine. There we go. The light gray ones are the patient. So we're going to look at our alarm limits. Minute ventilation low is 10.3. Sorry, the high is 10. The low is around 3. Airway pressure is 40 for the high. The volume is 1. The high respiratory rate is 35. The apnea time is 15 seconds. That is their protocol here. So we're done looking at our alarm settings and making sure those are where that we want them. This one does have the heated humidification on it. If I wanted to give a nebulizer, oh crap! Oh, I don't know what I did with it. There it is. This one has the ability to, let's see, I would take this filter out for one thing, so that the medication could get through. I would take my medication, squirt it in my little cup, which I can use this for. So I would squirt that in my cup, hook it into my T-piece, all while wearing gloves and trying not to contaminate everything. Because every time you open the circuit, there's a risk of getting bacteria in there. This one has the ability to do it while it's ventilating without having to hook it up to the flow meter. There's a little doodad under there. We hit nebulizer, acknowledge, and y'all can. It only gives it on the inspiratory, so that's super helpful. Let's say I wanted to change my mode. We have CMV, MMV, CPAPs, the pressure support, PCV, and more. Let's do pressure control plus, because it's got a little pressure support with it. So O2 is 50. None of my settings changed from my previous. My pressure inspiratory is 20. PEEP is 5. So we'll activate that one. So now we're in pressure control with plus support. I'm still doing my nebulizer. We would want to reassess our patient, check their ABGs, and see how they're doing. So let's say I didn't want to give a breathing treatment. Let's say I wanted to give an MDI. This is going to go nuts. No, it's not. No, it's not. No, it's not. I can stay. So we have this little thing here that snaps together and would be in the circuit. Pull that out. That's our spacer for our MDI. You would take the canister out of the inhaler, which this is actually a DPI. It's my personal one. So you take the canister out, shake it up just like you normally would. There's a little teeny tiny port right there you would attach it to. This would be in your circuit. I'm just going to take my nebulizer out. Really upset it. Here we go. That'll work. So I would add it into my circuit, push it out, try to time it with my inspiratory time, or do an inspiratory hold manually at the same time, so that I can squirt my medication and get them to hold it. I'm just going to leave that on nebulizer for a minute. So another thing we would want to do is do a little bit of oral care. The only mannequin I could find that was intubated is this little guy. Oops. Please shut up. Okay, so I have this. So we would want to do oral cares every so often. So every time you do a vent check, you would want to check your cuff pressures, which this is an infant, so it's not cuffed. You want that right around 20, between 20 and 30. So we would have our suction, and we would suction at around the ET tube, just to get all the gunk out of there. We also have our oral care kit, which some of them you can hook up to suction, not this, but well, this kit with the little fake toothbrush you can. So you can hook this up to suction and brush the teeth. You want to move your ET tube every so often, so you might start off on, say, the right cheek, and then later on in your shift move it to the middle, and then the left cheek, and keep doing that through your shift so that the pressure sores don't happen. You want to look at the markings on it, make sure you didn't pull it out or push it in more at the same time. So let's say I cannot do suction with this ET tube. I know there's no way this is going to go down there. We'll give it a shot. So let's see. This is going to go funny. If I blow my little lungs off, it'll be hilarious. So it will be hooked up to my ET tube. That's actually working pretty well. So it is not going to go in there, I'm right. This will be hooked up to our patient's ET tube. We would push this down in. I like to hold my breath. One of the RTs suggested that. Squeeze and pull. It does not like it. If I need to lavage it, I can take one of these little pink bullets right here and squirt into this little port right here and lavage the patient a little bit, suction that out to help get out some thicker secretions. I can also bend my tubing and use the suction to kind of get some of the condensate out of there. I've watched them do that several times. I can also just suction the saline so that I can kind of keep that suction tubing clean. So we covered the settings, nebulizer, MDI, all of that good stuff. Yeah, I'm not sure what else I would cover. Thank you.